Hello, I am Marwan Abourass. In a recent continuing education seminar for a newly graduate dentist, it was revealed that they were instructed that teeth with long-standing substandard endodontic treatment and post, despite showing no lesions or symptoms, could undergo crown restoration without requiring endodontic retreatment. When I inquired about the reasoning behind this approach, it was linked to not waking a sleeping dog. Not waking a sleeping dog. I cannot avoid expressing my thoughts on this. This approach, prevalent back in the 1950s and prior to the establishment of endodontics as valid dental specialties, is severely outdated and falls behind contemporary standards of endodontic care. It's old, it's outdated. It's a condition that contributes today to the global 53% prevalence of apical periodontitis. This approach is not supported by substantial evidence and carries many risks. Here's why. Diagnostic radiographs possess limited accuracy. According to Estrella in 2008 and his group, in their study of 1,425 endodontically treated teeth, ETT, they found the following accuracies in detecting AP, apical periodontitis. In the OPG, the accuracy was 17.6%. In the PA radiographs was 35.3%. And in the CBCT, it was 63.3%. This is very notable. There are so many negative diagnostic findings, especially at the early stages of AP, as demonstrated back in 1967 by Brinoff. Early stages, we don't see AP. Number two, in contemporary endodontic treatment, technically inferior root canal, retreatment is a standard of care. It's consensus. It's never based on wait and see. Let's watch it. When there is a problem, retreatment outcomes is very predictable. It's a standard of care since 1979 or even before. Bergenholtz in Sweden demonstrated that endodontic treatment conducted by undergraduate dental students resolved 78% of apical pathologies due to technically poor root canal fillings. And what appeared to be calcified canals, they were in fact patent clinically once you get in. Number three, the optimal way to manage inferior endodontic treatment, which may include a need for a new restoration, or you may have symptoms, or the patient is totally asymptomatic. We have a standard. Requires that you, the general practitioner, investigate the case, eliminate the defective restorations. This approach is my 4R operational diagnosis system. It's based on operational, physical, not radiographic evidence. You will be able to do a comprehensive assessment technically of the inadequate coronal restoration and even the root canal. And that is very possible because it's been my experience that substandard endodontics and substandard restorations are linked with coronal and apical microleakage, which breaks down the cement and make it easy to remove and make the path of endodontic retreatment possible. If you or the clinician lacks the necessary competence, skill, then the appropriate standard of care would be to refer the patient to an endodontist. Endodontists today, with their specialized training, are well prepared to manage such complex scenarios and possible comprehensive understanding of the many issues associated with poor, deficient, substandard endodontics. They are proficient in using advanced technology, ultrasonic equipment, microscopes, CBCT, superior filling material. They have the know-how to do it. And that is good for the patient. And that is good for the public. And that is good for the national health care, oral health care. In conclusion, endodontic retreatment acts a remedial procedure for a complication, antiquated approaches that were done many years ago, and many philosophies and ideologies that I cannot relate to anymore. The ability of general practitioner to recognize both their capability and limitations, paired with willingness to delegate, to refer, is very important in modern dentistry. That optimize the outcome, that guarantee good outcome, good prognosis. Thank you for listening.